Dr. Riemann is the Clinical Director of OCD Center and Cognitive Behavioral Therapy Services at Rogers Memorial Hospital. Dr. Abramowitz is the Professor and Associate Chair of Psychology and Research Professor of Psychiatry at the University of North Carolina at Chapel Hill. He's also the Director of the Anxiety and Stress Disorders Clinic. For the next 30 minutes, we'll be listening in on their conversation about the latest theories on OCD. They'll be covering some essential points that are key to a successful recovery. During their conversation, we'll be monitoring the live chat and Twitter feed, and then selecting questions for them to respond to in the last 20 minutes. Both options are available on the left side of your screen. If you use live chat, simply type the question and select OK. On Twitter, use the hashtag RogersOCD. Now let me turn it over to Dr. Jon Abramowitz to start the conversation.
Thanks, Megan, for including me. Hey, Brad, how's it going?
Very good, John. Thanks so much for joining us today. I'm really excited about this opportunity.
Yeah, me too. So I guess we're talking about OCD, one of my favorite topics to talk about. And I guess to start off with, we should probably talk about kind of just the definition of OCD. How do you know when it's OCD? And really, OCD involves two major types of symptoms. So one is obsessions, and these are unwanted, intrusive thoughts that, you know, they cause a lot of distress for you when you experience them. You want to try to get them out of your mind, but they keep recurring over and over again. And obsessions tend to, just to give you some examples, they tend to fall into some different categories. So people often will have obsessions about contamination or about the fear that they've done something or they haven't done enough to prevent something bad from happening, and they're going to be responsible for something bad happening, like what if I hit someone with my car, or what if I made some sort of a mistake. Another thing that people have obsessions about are the sense that things aren't just right or complete. And then you can also have obsessional thoughts about kind of taboo topics like sex or blasphemy, or kind of harm and violence. And obsessions create anxiety. They provoke distress, and nobody likes to feel distressed or anxious. So people who have OCD use compulsive behaviors like rituals to try to reduce that anxiety and kind of get away from their obsessional thought. So they might do things like, you know, washing their hands to try to reduce feelings about contamination, thoughts about contamination, or checking to try to make sure that they're not responsible for something bad happening, or putting things in order to make sure that things are just right. Or sometimes rituals can be mental rituals, where they're kind of repeating something in their mind, or you might have compulsions that involve checking with other people, asking for reassurance and stuff like that. Brad, anything to add? Any other types of rituals that maybe you run into?
You know, nothing really to add, John, other than the fact that I think the key points that you brought up for everybody to keep in mind is that, you know, these obsessional thoughts are absolutely unwanted. In addition to that, as you pointed out, compulsions don't only have to be things we can observe, but can be things that people do silently in their own mind. And that's really important because we do get a lot of people who will call us and say, hey, I think I'm just pure obsessional because all I do is the thinking part. And of course, as you pointed out, those thoughts may be designed to try to reduce that anxiety and therefore are a compulsion. So dead on with your descriptions, just some things that I think is always important really to emphasize.
Yeah, and actually just to reiterate one thing that you touched on is that there's a relationship between obsessions and compulsions. And I know in our DSM, actually, it says you need to have either obsessions or compulsions to meet the criteria for OCD. In reality, the vast, vast, vast majority of people have both obsessions and compulsions, and they're related. The compulsions are acts that the person performs to try to get out of that obsessional fear.
Yeah, and as you pointed out, even in the definitions of obsessions, they refer to compulsions, and in the definitions of compulsions, they refer to obsessions. So to some extent, I would even go further than that. I'm not sure that that anybody has one or the other. I think really all of the patients we've seen, and I know we published a study in your journal even last year that had nearly 1,100 participants, where all of them reported both obsessions and compulsions.
Yeah, I think that's an important point. We've also been talking about how OCD involves a lot of anxiety, and I think of OCD as an anxiety disorder. It used to be, up until last May, OCD was classified along with things like phobias and panic attacks and post-traumatic stress disorder as an anxiety disorder. And now in the new DSM-5 that came out about 5 months ago or so, OCD was actually removed from the anxiety disorders to a new class called the Obsessive-compulsive related disorders that includes problems like hoarding and hair pulling, trichotillomania, skin picking. There might be a body dysmorphic disorder. There might be one or two others. This is actually something that I tend to disagree with. Maybe we can talk about that further a little bit later on. But I think of anxiety really as involving fear. I think of OCD as really as involving fear and anxiety as the main component. I don't know if you would agree with that too.
Yeah, John, this is an interesting area that you and I have talked about for many years. I mean, this whole notion of pulling OCD out of the anxiety disorders, of course, has been proposed and thought about for years before the actual DSM-5 came out, and so we kind of knew what was coming for a long time. And you and I had both said that we really couldn't figure out quite what the rationale was for pulling out obsessive-compulsive disorder when clearly the number one characteristic was high levels of anxiety, and almost by default it has to be an anxiety disorder. What I would have to say is, since I've seen the DSM-5 now, and I feel less strongly about that. I think maybe time has just kind of wore me down a little bit, but I also think that there was some rationale that I guess I wasn't necessarily aware of early on. So, for example, John, if you think about it, they pulled OCD and PTSD out of the anxiety disorders, and then plugged in a couple of others, such as separation anxiety disorder, selective mutism, and so to some extent, if they, anxiety disorders is so all-encompassing, at some point there would have been just so many conditions in that category that it just would have kind of been overwhelming. So I think, to some extent, I don't know if they're saying, well, it's not because anxiety is a hallmark issue, it's just kind of somewhat subclassifying and kind of making room for things like separation anxiety disorder, which should have been an anxiety disorder a long time ago. So I guess I feel a little less strong about that now.
Yeah, I can certainly see that point. I guess one thing we can talk about is how similar is, and maybe this will come up later on, how similar is OCD to the other problems that have been classified as OCD-related disorders. And I know that there are some disagreements about that, but we can come back to that. One thing that's important to know is that OCD is not a rare problem. About 2 to 3% of adults and about 1 to 2% of kids in the United States, and actually I think those figures are pretty much the same worldwide, have OCD. And so certainly in the U.S. we're talking about millions and millions of well, not millions and millions, but maybe a couple of million people. We don't know a whole lot about what causes OCD. And I can talk about some of the guesses that we have, although they're actually not really very good guesses. One of the guesses about the cause of OCD is that there's something wrong with structures in the brain. And the research on this is actually very inconsistent relative to how strongly this view is sometimes kind of propagated, I guess, in the literature and by certain organizations and things like that. But I think it's important for our audience to understand that there's actually no proof that people with OCD have an abnormal brain structure or abnormal brain functioning. Now, certainly, the research shows that there are differences between people with OCD and people without OCD in terms of what their brain looks like when it's being scanned in a machine like an MRI machine or something like that. But you know what studies have really showed us is that what's happening is that when you have OCD, when you have a lot of anxiety, when you're stressed out, your brain actually does things differently, and it responds differently than when you're kind of calm and relaxed. And so it's really kind of it's not a surprise that folks with OCD, that their brains would light up when they're being scanned, because they're under more stress, they have more anxiety relative to, let's say a person without OCD who doesn't have any psychological disorder, who would be, at least not an anxiety disorder, who would be more calm. And so just because you see a difference doesn't mean that one is the cause of the other. And I guess the only other thing I'd say about that is that people, if you had some of the brain problems that are being linked to OCD in the literature, I would say that OCD would really be the least of your problems. You have a lot more to worry about than just OCD. The brain is like one of the most complex things in the universe. And so the models that we have are really overly simplistic, and they really don't help us to understand much about OCD.
Yeah, and Jon, you bring up a great effect, that a great point of kind of cause and consequence. That these studies, as you mentioned, they may show differences, but is that a causal reason? Is that why someone has OCD, or more, as you pointed out, is it more of a consequence of having all of these unwanted anxiety-producing thoughts over and over and over again? And I think that's a very good point.
Thanks. Another model, another theory that's kind of out there is that OCD is the result of a chemical imbalance. So a problem with what are called neurotransmitters. And a good example of that we often hear linked with OCD is serotonin. And again, I don't think this is a good theory because the research just isn't there to prove it. It is the drug industry's favorite model because they want us to think that OCD is caused by a problem with serotonin, and then we have these serotonin medicines that we need to fix this problem, and so we can sell a lot of serotonin reuptake inhibitors, SSRIs. But there's no scientific evidence that people with OCD have problems with their serotonin, and that causes them to have OCD. Again, if you had problems with serotonin, OCD would be the least of your worries. Serotonin is involved in so many different functions in humans and in other animals as well. And I guess the strongest link here the strongest evidence for some sort of link between serotonin and OCD is that serotonin drugs do work. SSRIs do work or can work for some people who have OCD. And so what some people want to do is they want to reason backward and say, well, okay, so you take this serotonin medicine and it helps you with OCD. OCD must be caused by a problem with serotonin. But that's really kind of faulty reasoning. And let me kind of explain why that is. If you have a headache and you take aspirin and the headache goes away, we wouldn't say that your headache was caused by a lack of aspirin, right? And so the same thing, we don't know how these serotonin medicines work. And we, again, don't understand very well how the brain works, and we don't understand the causes of OCD. So I think it's premature to say that OCD is caused by some sort of chemical imbalance. I think it's very simplistic.
Yeah, and Jon, I've always kind of verbalized it as somewhat reverse science, right? I mean, normally in science we come up with a hypothesis, and then we create a test designed to test that hypothesis, trying to control for every other alternative explanation for why we would get the results, so that if we do get the results we anticipate, we can pretty well conclude that it must be because of our hypothesis. But this really, the serotonin hypothesis kind of came out of a test, right? I mean, once we found out that OCD was a common problem, we began to try to treat it, and we were kind of throwing different medicines and so forth at patients, and which is equivalent to tests. And then, anafranil was found to be helpful, and as a result, we kind of came up with a serotonin hypothesis out of this test, which is really reverse science. And I think you're absolutely correct. I mean, our knowledge of neurochemistry is in its infancy, and it may not be quite as simple as that. But as you pointed out, I mean, the one important fact certainly is that these medicines are helpful, but we're not really sure why.
We're not sure why. So another theory is that OCD is a genetic disorder. You often hear it referred to as a genetic disease. And again, I don't think we don't have the evidence to show that. There have been lots and lots of genetic studies looking at OCD, and none of them are consistent. There have been meta-analyses that have been done, so these are summaries of all the studies, and they really don't tell us very much consistent about if there's any sort of genetics to OCD at all. Yes, OCD runs in families, but so do lots of problems with psychological disorders, and so do other anxiety disorders. And by the way, genes aren't the only things that can dictate what runs in families, but also the family environment can dictate that too. So again, we really don't know. And that kind of brings us to this idea of, how much is the environment involved in OCD? And again, it's just we just don't have a good sense of can you learn to have OCD? There are some people that think, well, certain situations give rise to developing OCD, but again, you see lots of people that are in these situations that don't develop OCD, like having a traumatic childhood or having certain experiences. Many people who go through that end up doing just fine. So I guess the take-home message from what I want to say really is that we don't know what causes OCD. It's probably a combination of lots of different factors. Right now, we just don't understand. The good news, if there is any good news in that, is that we don't have to know about the causes of OCD in order to treat it very well. We have some effective treatments, and so I know you're going to talk a little bit about that.
Yeah, thanks, John. The only thing I want to kind of mention before we get into treatment options and those kinds of things, you were talking about how common this problem is, and I think that that's a very important take-home message for our listeners. It's the fourth most common psychiatric problem in the United States. In addition to being common, it's extremely debilitating. John, if you remember right, the World Health Organization a few years back had listed OCD as the 10th leading cause of disability in the developed world, and not just for psychiatric conditions, but medical conditions as well. So, I mean, it's a common and debilitating problem. But the good news is it's also very treatable when treated properly. And I do want to talk a little bit about treatment and certainly get your input on a lot of this as well. First, just to talk about medication briefly, I'm a psychologist, not a psychiatrist, but certainly having worked in this arena for 20 or 25 years now, I certainly feel I can speak to it to some extent. There are medications that have obviously been federally approved to treat OCD in the United States that have been found to, on average, produce about 30% symptom relief. They are rarely enough in and of themselves, but can prove to be helpful. As John mentioned, the serotonin hypothesis came out of really this work, the fact that these medicines do help reduce symptoms for OCD, and that at least one of the things we know they do is kind of block the reabsorption of this brain chemical serotonin into our system, kind of keeping it out in our system longer to kind of do the magic, whatever serotonin does. And so these medicines are there. The positive thing is they're also quite readily available. Most psychiatrists, all psychiatrists, and I'm assuming most even general practitioners are going to be comfortable prescribing these. So certainly they're available to those that suffer from OCD. But as I said, rarely enough in and of themselves, lots of variability in terms of treatment effect, on average about 30% reduction. The treatment of choice, as I'm assuming most of you know, is a psychological intervention out of the school of behavior therapy known as exposure and ritual prevention. And as John was pointing out, OCD has both obsessions and compulsions, and so the treatment itself has 2 points as well. The exposure really targets the obsessional thoughts, ritual prevention targeting the compulsions or rituals. This is nothing new. The first published study on exposure and ritual prevention was done in the 60s. The problem is there's just not a lot of providers trained in this, as we're going to probably talk a lot more about here this evening. Exposure and ritual prevention is based on the process of habituation, which basically says, in terms of anxiety, if you place yourself in a feared situation long enough, which is the exposure component, your anxiety will come down with nothing but the passage of time. And of course, the nothing but passage of time refers to the need to prevent the ritual or to block that normal response or compulsion that someone has. So in a nutshell, exposure and ritual prevention is literally placing people into their feared situations and then asking them to resist that normal compulsion or ritual, which of course can be much easier said than done. To me, go ahead. Did you have some thoughts?
Oh, no, go ahead. What I was gonna bring up one thing,
yeah.
And that is, there's actually some new research showing that you mentioned habituation. There's some new research showing that even when patients do exposure, even sometimes their anxiety doesn't go down immediately, or sometimes it could take a long time, or even not at all. And what some of that new research is showing is that that's actually okay too, and that people with OCD, if that anxiety doesn't go down, they actually learn, hey, you know what? this anxiety isn't the end of the world. I can tolerate this. I can get through it. Sure, it would be nice if the anxiety went down, but just to prove that I can get through that, even if it's not going to go away, that doesn't have to stop me from doing what I want to do. It's kind of one of the newer directions in terms of exposure therapy.
Yeah, but John, obviously most people do experience that habituation. I mean, I think Edna Foa did a study many years ago that like 97% of the people do experience this anxiety going down with nothing but the passage of time by blocking that ritual. But as you're pointing out, that is not necessarily essential to benefit behaviorally and improvement in life. Right?
We're having technical difficulties out of Roger. Oh, there you go. Okay.
Right. Yeah, does that make sense?
Yeah.
Yeah. You know, the issue, of course, is, again, the exposure and ritual prevention seems to be the key ingredient. As we mentioned, the vast majority of people do habituate to their feared situations. But to me, John, there's really three keys to making exposure functional or therapeutic and productive. One is that exposure has to be kind of done in a prolonged fashion. In other words, it doesn't really do anyone any good to just kind of briefly introduce themselves into their feared situation and then quickly scamper out. Someone needs to kind of enter this feared situation, stay in this feared situation long enough for that process of habituation to occur. And the analogy that I like to use with people I'm working with is kind of water temperature. So, for example, if we were to jump into a lake, say this time of year in Wisconsin, our lakes are pretty cold, you're going to jump in and it's going to be cold. And if you just immediately back out and jump out of there, all you'll really have experienced is that water being really, really cold. On the other hand, if you can somehow kind of get yourself to stay in that water, your body begins to adjust to it. Your body begins to habituate to it. And if you can stay in that water long enough, you tend to start finding yourself saying things like, hey, water's kind of warming up, huh? Well, of course, the water temperature hasn't changed at all, but your body is habituated to that. And I think the idea is, again, if you can place yourself into a feared situation long enough, you experience this anxiety reduction, or it's almost as if the water temperature is increasing in my analogy.
Yeah, I think that's real important, and I'll just say that a lot of people come into therapy and they say, well, I've tried exposure therapy on my own, and I ask them, well, okay, so what did you do? Well, I touch door handles all the time. I'm doing exposure all the time. I'm always around people that are contaminated. I'm always around these different situations. But when you really ask them about how they handle those situations, they're not staying in the lake. They're jumping right back out of the water. And that's the difference between kind of random, kind of everyday little exposures versus real therapeutic exposure that it takes to get over a problem like OCD.
Yeah, great point. And then in addition to it being necessary to be done in a prolonged fashion, I think the second key is it has to be repetitive. And so somebody has to be willing and able to kind of just continue to jump into that water. And what you find here is a different kind of habituation. In other words, that first, by doing prolonged exposure, you get what we call within trial habituation or within exposure habituation. So that anxiety rating kind of starts off higher and reduces while you stay in that water. But through repetition, we get between trial habituation, which is where things just continue to get easier and easier. In other words, at some point, if you do enough trials, someone will be able to kind of jump in that water, again, getting back to that analogy, and feel like the water is fine, it's comfortable. Mm-hmm. So, the prolonged repetitive nature is very important, and then really it being done in a graduated fashion. It's very difficult and really probably unrealistic to expect most people to kind of dive in to their worst fears and really be able to comply with doing the exposure in a prolonged, repetitive way, and then also keeping in mind that second part of treatment, which is the ritual prevention. We typically, John, I don't know where you start people off in terms of their anxiety ratings, but we usually start people off just slightly below halfway point. So whether if somebody uses a 0 to 100 scale, somebody could start off at 40, 45. If somebody uses a 0 to 10 scale, they maybe start off at about a 4. But we generally start people off a little bit below the midpoint, just as a way of really trying to increase compliance. Most people can kind of push themselves in a challenging but manageable fashion into these exercises just below that midpoint and be able to do it in a prolonged fashion, be able to do it repetitively so they can get that therapeutic benefit.
Yeah, and I think that some people are like, they'll say, well, we should start with the easiest hierarchy item, the easiest exposure at 10 or 20 or 1 or 2 on a 10-point scale, and what we tell them is that really we could do that, but that's kind of not going to help you very much. We need to start with something that provokes some distress, so that you can see that you can manage that distress. And starting with something too easy, it's kind of well, you could probably get away with not having to do that.
Yeah, and just lastly, I just wanted to make some comments about really kind of the outcomes that have been found with exposure and ritual prevention. Overall success rates. If you kind of look at all of these dozens and dozens of studies that have been done over the years in randomized, controlled kind of scientific environments, or even in real-world environment kind of hospital settings, overall success rates with ERP alone are about 80%, with significant symptom reduction. The vast majority of people are able to really return back to a much more manageable level of anxiety in their life and be able to return back to being productive, whether it's at school or at work. And so, kind of the take-home message is obviously OCD is common, as you pointed out, Jon. It's very debilitating, but it's also very, very treatable when treated properly. The biggest problem with exposure and ritual prevention is really trying to find someone who knows how to do it, and then sadly, there's a real lack of availability for exposure and ritual prevention really across the country.
Yeah, I would completely agree. This is a treatment that has really changed the prognosis of OCD over the last 40 or 50 years. As you mentioned, before the 1960s, really before the widespread use of behavioral therapy, if you were diagnosed with OCD, you were pretty much, it's kind of a life sentence. You were going to have that over the long term. Psychoanalysis, psychodynamic therapies, humanistic therapies, they can help the person maybe to kind of cope with the problem, but those kinds of treatments aren't going to get rid of obsessions and compulsions the way that cognitive behavior therapy can in the long run. Exposure and response or ritual prevention, the way you're talking about. It's been a revolutionary treatment, and I completely agree that more needs to be done to train folks to use this treatment well in the real world settings.
Yeah. And another point, Jon, you were talking before about kind of the biological studies that have been done, whether they be imaging studies or whatever it might be, and one of course, the interesting things, and you and I haven't probably had much of a chance to talk about this over the years, but one of the interesting things, of course, is there are studies that show that people doing exposure and ritual prevention also have been shown to have changes in these imaging studies, these PET scan studies, and so even if we argued for a moment that biology is behind this, apparently cognitive behavioral therapy can kind of switch that. Or as we pointed out, maybe those biological abnormalities are really consequences of having OCD, and by doing ERP, you kind of shut that down as well.
Yeah, I mean, I agree, and we need our biology in order to do anything, whether it's an OCD thought or behavior or a non-OCD thought or behavior. All of our behaviors, all of our thoughts are kind of implemented within our biology. So at some level, of course, biology has something to do with OCD, but there's no evidence that people with OCD have something wrong with their brains, whether it's the structure of their brain or the function of their brain or neurotransmitter systems. I think that what we're seeing is exactly what you're talking about. It's the effects of having OCD. This is your brain on OCD, basically. This is what when you have OCD, this is what your brain looks like, because you're stressed out and you're obsessing and compulsing, and this is what that looks like when you take a picture of the brain.
Yeah, I remember in graduate school, we used to talk about information processing theories of obsessive-compulsive disorder, anxiety disorders. That was really kind of the research interest of our lab back then. And the old question was, do people with anxiety disorders process information differently, or do they just simply process different information? Right. And by processing different information, that could be why a brain lights up in a certain way, because they tend to be processing more danger and fear kind of information than your normal person would, your typical person would.
Yeah, there's plenty of evidence showing that people with OCD tend to focus on threatening stuff, whereas people without just don't without OCD, without anxiety, they just don't think about threatening stuff as much. When you have OCD, you kind of become hyper vigilant to things that could cause danger, the things that could cause obsessions, which makes sense. Things that we're anxious about, we tend to become preoccupied with them, and that can help us if we're preparing for a job interview or getting ready to ask someone out on a date. We become preoccupied with whatever that is. Of course, when you have OCD, you're worrying about things that are much lower risk and that are often kind of exaggerated fears. And so it turns into becoming preoccupied with all sorts of stuff that's ubiquitous in the environment, unwanted thoughts and sources of contamination, but they're not really dangerous.
Yeah, and Jon, you're hitting on an important point, kind of the universal nature of unwanted thoughts, right? I mean, in other words, I think sometimes people think that people without OCD never get unwanted anxiety-producing thoughts, and certainly, as you know, obsessions are universal. We all have them from time to time, and so then the next question is, well, what's the difference between somebody who has OCD and somebody who doesn't? It must be the kind of obsessional thoughts, right? Nope. We all get the same kinds of thoughts from time to time, and really the difference seems to be between somebody who has OCD and somebody who doesn't is just the frequency and intensity of these thoughts. And Jon, if I remember right, you did a study on harming obsessions, if I remember right, that found that the vast majority of parents of newborn children were reporting these kinds of thoughts even if they didn't have OCD.
Yeah, in fact, both mothers and fathers of new babies reported that from time to time they would get thoughts, what if I harm the baby? What if I drop the baby by mistake? What if I, touch the baby sexually inappropriately? That, something like, I think it was like 70 to 80% of new parents experience that. Of course, not everyone develops OCD. And one of the things that we found, this was a study that followed parents out over 3 months, we found that new parents who appraised those thoughts, who basically thought that those thoughts meant something really important about them. I'm a terrible person for thinking this. I shouldn't be having these kinds of thoughts. I might act on these thoughts in a negative way. People who believe that their thoughts were really, really important, they're the ones that went on to develop more problems with obsessional symptoms, relative to everyone else who just kind of said, oh, that's just one of those strange thoughts. That's not a big deal.
Yeah, and I mean, that gets us to kind of that thought suppression idea, right? I mean, in other words, those people who tagged those thoughts with some level of importance generally are also more likely to be the people who try to not think of those things.
Right.
And of course, what happens in our mind when we try not to think of something, we think of it, right? The old white bear paradigm in the lab where try not to think of a white bear and what pops into your mind, an image of a white bear. And so to some extent, these efforts to not think these bad thoughts, because as you pointed out, they're kind of tagging them with some sort of level of importance or meaning, has that reciprocal effect. The more they try not to have these thoughts, the more they have them.
Yeah, I think that's exactly what's going on. For people who have OCD, they're trying to resist their unwanted thoughts. They appraise these thoughts as really bad and something that have to be dealt with, and so they're trying to resist them. And sometimes that resistance goes on in your mind. Okay, don't think about it, don't think about it. Sometimes it's more of a behavioral reaction, like washing to get rid of the thoughts and the feelings of contamination, and that just kind of gets this whole big vicious cycle going around and around, where the person's doing rituals, they pay more attention to their thoughts. The rituals sometimes work, right? Because if you wash your hands a lot, you don't get sick. Of course, you never learn that, well, you probably wouldn't get sick anyway, even if you didn't wash your hands after touching a doorknob. So the person gets into this cycle of kind of thinking that these thoughts are more important than they really are, and they got to do something about them.
And of course, that's the basic foundation of exposure and ritual prevention. In other words, these individuals are trying not to have these thoughts, and then you and I place them in situations that actually deliberately produce those thoughts, but again, hopefully in a graduated, more manageable kind of fashion. And then I think overall, Jon, wouldn't you agree that one of the kind of the things that people learn through exposure and ritual prevention, and as a learning-based kind of therapy, is it is okay to have these thoughts. And as you pointed out, some of your participants in your study just kind of reported having these thoughts, but weren't alarmed by them, just kind of discarded them and moved on. Whereas people who are alarmed by these thoughts cannot move on, and in a sense, ERP is just kind of unlearning that.
It's exactly what it is. It's okay to have certain thoughts, even those taboo thoughts. It's okay to feel anxious. That anxiety doesn't stay forever. I can get through this kind of thing. And yeah, exposure and response prevention is basically like, bring it on. Let me prove to myself that I can get through this, and that this is something that I can, that I can get through, that I can manage. I don't have to do these rituals to feel better. I can be okay even when I'm anxious, even when I'm thinking about these unwanted thoughts.
Yeah.
So that's a lot of great information, but the time's flying by, and we do have some questions coming in.
Great.
But before we start with the questions, I would just like to take a moment to say how important it is to offer support to people with OCD, as well as their family and friends. The International OCD Foundation and its affiliates across the country, like OCD Wisconsin, are united in a mission to help people with OCD to live full and productive lives. Our aim is to access effective treatment and end stigma associated with mental health issues, and to foster a community for people with OCD, their families, and the professionals who treat them. If you or someone you know has OCD, there's a wealth of information and resources to help you. I encourage you to check out our website at ocdwisconsin.org to learn more. Now, we do have some questions that have come in during your conversation that I'd like to ask you to respond to, please. Brad, why don't we start with you? A question came in about the Y box. What is the Y box?
Good question.
Good question. The Y box is the Yale-Brown Obsessive-compulsive scale, or shortened up to be called the Y box. The Y box is really the gold standard for OCD assessment, developed by Wayne Goodman way back in 1989, believe it or not. You will never see a kind of a treatment outcome study, whether it's medication or exposure and ritual prevention or cognitive behavioral therapy. You'll never see a treatment outcome study that doesn't use the severity rating scale of the Y box as its pre-post measure of progress. So you give somebody a severity rating scale before treatment, and you give it to them after treatment, and of course the change in that score reflects their progress. And John, you want to talk a little bit about the Y box symptom checklist?
Sure. Well, I think we should also mention the Y box. The severity rating goes from 0 to 40, and so if you have a score, most people probably have a Y box score between 0 to 7, which would be kind of subclinical. But if you're getting up around 25, 30 or so, then that's an indication of pretty severe symptoms. There's also a checklist of, I don't know, probably close to 80 to 100 specific types of obsessions and compulsions that a mental health professional might sit down with you and say, okay, do you have obsessional thoughts about contamination from things like doorknobs and floors? Check, or maybe not. Do you worry about hitting someone with a car? And really specific kinds of symptoms that you may or may not have. And the idea is to kind of go through this exhaustive or more or less exhaustive list. It really helps the clinician to get a good sense of the kinds of OCD symptoms that you as the patient might have. OCD is so variable. Everyone has their own types of symptoms, and so it's really important for a clinician to do a really thorough interview, and that's the Y box checklist is a good way of doing that.
Yeah, and John, you brought up a good point about the kind of what the scores mean, and as you pointed out, it's a 0 to 40 scale on severity rating. 0 to 7 is considered subclinical OCD, 8 to 15 would be considered mild, 16 to 23 moderate, 24 to 31 is considered severe, and an interesting point here, just kind of, again, emphasizing the debilitating nature of OCD. I believe the average person with OCD scores 24 on the Y box, which is actually in the severe range. So the average person with OCD has severe OCD, and then that 32 to 40 range is the extreme range. And John, we've kind of found that when someone gets close to 30, their lives kind of come to a halt. It's very hard for someone who scores that high to really maintain themselves in school or at work and socially, and life kind of stops for these folks around 30. Would you agree?
Yeah, I would agree. You and I probably see different populations of folks. You probably see more of those people at a place like Rogers, a residential program. In our outpatient program, we tend to see folks in the low to mid 20s, sometimes a little higher than that. But yeah, I would agree with what you're saying about that, for sure.
Thank
Another
you.
question.
And John, what about new therapies? A question came in about new therapies targeting glutamate, the level, menantine, and riluzole.
Okay, so I'm a clinical psychologist also, like Brad, and I'm not as familiar with some of these new medicines, some of these new treatments that target glutamate. I am familiar with kind of this movement away from serotonin and over to glutamate, which is another neurochemical, a chemical that's actually found all throughout our body, as a potential, kind of basis for OCD. And I gotta say that the use of these treatments, we're kind of putting the cart before the horse. We're using these kinds of treatments without a lot of solid evidence that glutamate is really involved in OCD, playing a big role in OCD. So I'll be honest and say that I don't know about the treatment outcome studies. I don't know if there are any of these big trials for these medicines, but I would be skeptical of any sort of medicine that targets one kind of neurotransmitter, one kind of chemical, so to speak, as involved in OCD. I gotta see a lot of good evidence before I would say, hey, these are, good treatments to use.
Yeah, and I would just say, first of all, I'm just really glad, John, that question came to you first and not me. But other than that, certainly glutamate is something that we're hearing more and more about. What I would emphasize here is it is, I think, really quite experimental at this point. In talking with physicians involved in some of this research, I do think that they're kind of excited about it, that if nothing else, it might provide an alternative. It may not necessarily be anything better than the SSRIs that we have, but it would provide another option for people that for some reason couldn't use an SSRI or probably more likely didn't benefit from them. But it is definitely in kind of this trial phase at this point.
And by the way, I mean, I think it's important for people to know if you're taking medicines for OCD and it's helping you, stay on the medication. We don't know what causes OCD. So just because, and probably also the causes for different people, OCD is so variable. Different people, it might be caused by different things. So if you're using a medicine and that's working, just because we're saying that some of these things are experimental, don't necessarily stop that because of that. If you're getting relief, then no matter how it's helping, it's helping, and that's at the end of the day, that's the most important thing.
Thank you. The next question that came in, I'm really happy it came in because it's probably the question that I get asked most often at OCD Wisconsin. How can I find a good provider?
Yeah.
Well, I'll try to take a whack at this first here, John. I mean, that's a great question. I think the first thing that I would advise people to do is go to the International OCD Foundation's website. It's a terrific resource for a variety of reasons, but one of which is kind of a find a therapist online directory, and you can plug in your hometown. You can within a certain number of miles of your hometown and find providers that are listed as professional members of the International OCD Foundation. Many of these providers are graduates of what's called the Behavioral Therapy Training Institutes, or the BTTIs, which is this intensive 3-day training that the IOCDF supports. Some of the providers, of course, are faculty members of the BTTIs, and so it's really a good place to kind of start. There are other organizations that also have Find Therapist directories, such as the Anxiety and Depression Association of America, or ADAA, and also the Association for Behavioral and Cognitive Therapies, ABCT, also has one. So I would really encourage using those as a resource. We use them all the time here to try to find follow-up care for patients that come here to Rogers, and we find them very, very helpful.
And I would just add to that, once you have identified a potential treatment provider, then you want to ask them some questions before you kind of get going to make sure that they really are going to use the state-of-the-art treatments. So, you've heard Brad and myself talking a little bit about exposure and response prevention here, but go online and read about that treatment and then ask that provider as if you don't know. Ask the provider, hey, what would you do for me? I have OCD. What kind of treatment? I've heard about this exposure thing. How does it work? and get them to explain to you what they would do to help you out. And if it sounds like what you've read about, what we've been talking about, then you're probably on the right track. A lot of people say that they do cognitive behavior therapy, or that they do exposure therapy, and then you go there and it ends up kind of not being the real deal. And so it's important to ask, where did you get your training? How many people have you worked with who have this problem? Tell me a little bit about the therapy, before you kind of get too deep into things.
Yeah, that's a great point, John. I mean, so many people spend more time figuring out, a contractor to, put new tile in their bathroom than they do their mental health care provider. And I think you absolutely have the right to kind of interview this person over the phone. Frankly, if they're not willing to give you any time over the phone, it's probably a message in and of itself. And the other thing I would say, John, to follow up to your point, is just kind of, not only do a lot of people say these things, but they also keep talking about how it's coming down the road. And I know that, besides an initial evaluation that we would do with someone, we begin hierarchy development in virtually the first session beyond the assessment point. And I've heard people saying, oh, well, I've been seeing this person for 8 or 10 sessions. We still haven't gotten going on hierarchy yet. They keep saying they're going to do it. John, what session do you begin to develop hierarchies?
Yeah, we're starting to talk about how that exposure hierarchy is going to look right from the get-go, and I'm explaining to them kind of how the therapy is going to work. When I work with people with OCD, we typically contract for like somewhere between 12, 16, maybe 20 sessions, and so if you're seeing a therapist and it's been much longer than that, this is a problem that really can be treated in 16 to 20 sessions in most cases, certainly not for everybody. But if you're seeing a therapist hundreds of sessions or years and years, it might be time to look for a different person.
And there's just simply no point in delaying the onset of developing hierarchy and assigning exposures. I mean, that's where I think a consumer can really kind of separate out whether they have somebody there or not. Is just, have we gotten into this in a reasonable amount of time? And as John and I were saying, a reasonable amount of time is really the first 1 or 2 sessions.
First session, yeah.
So a good screening question as you're making that call might be if you ask them if they do ERP and they don't sound like they know what you're talking about, to perhaps make another phone call.
Yeah, actually, that's a real problem.
I would even ask them, what do they do? I would keep it open-ended, because if you ask them if they do ERP, they might kind of know what you're looking for, and if they want your business, they'll say, yeah, oh yeah, we do that. I might say, hey, I have OCD. What do you use? What kind of treatment do you use for that? And let them tell you what they use, and say, hey, can you describe that for me? And make sure they know what they're talking about.
Yeah, and I think a couple of other important follow-ups would be things like how many people have you used that with, and really kind of what have your outcomes been.
Yeah.
Those are great suggestions. Thank you. Another question, John, does an OCD sufferer have to continue to do CBT and ERP the rest of their life?
That's another great question. And for most people, no. So for most people, and one of the things that is what I think is terrific about CBT and ERP is that you learn skills, as Brad was talking about. This is a skills-based therapy. This is not where you're going to the clinician and sitting on the couch and getting advice, or the clinician is analyzing your dreams or talking about your mother or something like that. This is where you're learning skills that no one can ever take away from you. And that's another difference between medicine and CBT. Medicine, you have to keep taking that pill because it gets metabolized inside your body. With CBT, you learn these skills that then you know how to use for the rest of your life. Sometimes you need to go back for some booster sessions occasionally when you might hit a rough patch. That's pretty normal. But for the most part, people learn what they need in the therapy, and then they're able to use that when they're done. I tell my patients that the aim of going into therapy, the goal of going into therapy, is to get out of therapy. In other words, learn what you have to learn and then go off and live your life.
Yeah, and the only thing I would add there, John, too, is another way we kind of explain it to people is that you may need exposure and ritual. You're going to need exposure and ritual prevention, to kind of artificially increase the amount of times you're exposed to a feared situation. So again, one of the keys is prolonged repetitive, and so you need to do this kind of structured work of deliberately putting yourself into these feared situations again and again and again, to the point where you lower your anxiety. But then life itself, following treatment, I think provides enough of a natural dose of exposure to kind of maintain the gains. And so, do you have to do CBT the rest of your life? Not the way we prescribe it, where you're deliberately placing yourself into these situations multiple times, but in a way, almost just kind of naturalistically, life has you continue to engage in that kind of a lifestyle of approaching these kinds of situations.
Really good point. Agree completely.
Another question, Brad, is there a known interaction between OCD and other anxiety disorders, and how does the treatment differ?
Well, when you say interactions, I'm assuming you mean like comorbidity, in terms of them coexisting together. I think Jon mentioned before that obsessive-compulsive disorder and what used to be other anxiety disorders, now anxiety disorders, because as you mentioned, OCD has been pulled out, but they do commonly co-occur. Depending on which one, the rates do differ. So there is certainly a relationship there, which again I think does make sense. Someone who's prone to kind of overestimate the likelihood of certain bad events occurring, such as getting HIV through coming in contact with things in their normal daily environment, like a doorknob, may also be more likely than most to, say, misinterpret a bodily sensation as an increased heart rate as a sign of an impending heart attack, a la panic disorder. So they do commonly co-occur, and from a treatment standpoint, there are differences, but there are also similarities. So if we're looking at just exposure, for example, the same 3 keys to making OCD exposure effective also apply to exposure for any other sort of phobic avoidance that may be associated with social anxiety or panic and agoraphobia or whatever it may be, meaning, again, the prolonged, repetitive, and graduated. The good news is to some extent treating those other conditions is actually a little easier because there's no rituals to prevent or block. So the keys of exposure can be applied to both. They don't have the ritual prevention, which makes it a little bit easier. So there is overlap, but there are some differences as well.
We have one more question here, and I'll throw it out to whoever wants to answer it because it's regarding medication. How does an OCD sufferer decide whether or not they should try an SSRI medication?
Well, go ahead, Jon. Why don't you start?
Please.
Okay. Again, I think the idea here, a very important message is this. If you have obsessive-compulsive disorder, you definitely want to be proactive and try to seek treatment. And depending on where you're located and depending on what resources you have, medication may be your only option. You may not have anyone within 10 hours of your home and have no ability to go to a place like Jon Abramowitz's clinic. Medications are a viable, effective option. How would you know whether you need to go on medication? The idea would be you should visit with a physician, describe your symptoms, and they would make a far more educated decision than I would in terms of whether you need that type of treatment or not. And as I said, for some, it's really the only thing they have available to them. But again, if you have a choice between exposure and ritual prevention and medication, you certainly want to be trying to access the exposure and ritual prevention simply because it is more effective. On the other hand, for some, it may be more effective to do a combination of the two. And Jon, we probably don't have time to talk about all of that kind of data, but it really is a decision that you and your physician need to make.
Yeah, I mean, there are pros and cons to any treatment. There are pros and cons to cognitive behavior therapy, and there are pros and cons to medicine. And I think with medication, the pros are, hey, the medicine does all the work inside your body. All you do is take the drug, so it's easy. You go on vacation, you take the medicine with you, and you don't have to go to therapy sessions, stuff like that. On the other hand, a medicine can produce side effects. Often those can be controlled by working with the dose. Again, you'd work with your doctor to change the dose around. Another downside for medicine is that you typically do need to continue to take that, as long as you want symptom relief. I guess another downside to medication is that, well, let's see, yeah, I mean, it's not as effective as cognitive behavior therapy. About 20 to 40% symptom reduction is the average with medication. But for some people, that's fine, and that is what they're interested in. We are a society that likes magic bullets and likes medicines, and so if that appeals to people and that works, then go for it. At the end of the day, getting help is the most important thing.
Well, our time is almost up. The hour has flown by. I'd like to thank Dr. Abramowitz and Dr. Riemann for their thoughtful, engaging conversation. I know that I learned a lot. If we were not able to answer your question, please know that we'll be posting a response page in a couple of days, as well as an archive of this video. So you'll have another opportunity to look at the information if you wanted to review something again. I'd like to thank the staff at Rogers Memorial Hospital for organizing this event tonight. I found it very beneficial, and I hope, it sounds like from the questions, that people out there were pretty engaged, and hope you got great information out of it. So again, Brad and John, thank you so much, and for everybody who participated tonight through questions or viewing, thanks for participating, and have a good night.
Thanks a lot.
Yep, thank you as well. Enjoyed it, John. See you soon.
See you, Brad.